Hello, I'm Andrew Monaghan, Policy and Research Manager at the HFMA, and you're listening to HFMA Talk, the podcast for NHS Finance. On today's episode, I'm joined by Craig Marriott, Deputy Director of Finance at NHS Lothian and Chair of the HFMA Scotland branch, to understand more about the impact of Covid-19 in Scotland. Hi Craig, thank you for joining us today. Firstly, can I ask you to describe your organisation, the population you serve and the types of services you deliver?
Okay, good morning. My name's Craig Marriott. I'm Deputy Director of Finance for NHS Lothian. NHS Lothian is one of 14 territorial health boards in Scotland. We serve a population of just over 800,000, about 850,000. We're a tertiary centre. So we've got all the normal tertiary services that come with that in terms of supporting the region, which tends to be services for Fife and for Borders and their other health boards in our region. We operate out of kind of three main hospital acute sites, and we've also got a large mental health facility as well. So yeah, I mean it's a pretty full-on health population with a lot of issues. We have got quite a wide student population as well, so certainly within Edinburgh that does have an impact. We also tend to, in normal times, have quite a transient population just in terms of tourism. And we have the kind of peaks that you get along with tourism in terms of the festival as well. So, I mean, we're a pretty modern healthcare service. With quite a large population we've got to deal with. Our budget is about £1.7 billion, so I mean it is significant, and a lot of that does include our services that we provide for other areas.
Okay, and I believe, am I right in thinking you're the second largest health community in the UK?
Yeah, I mean, Glasgow's the largest board in Scotland, but I mean, we tend to feel that we're the premier board itself just because we're the capital. But yeah, no, Glasgow's bigger again. Their budget is, it must be about £2.5 billion. But in terms of the two population mixes, they're very different in terms of the population needs and just in terms of the demographics and the diversity of that population. So yeah, there's kind of two slightly different, but yeah, Glasgow is the biggest board that we've got in Scotland. And I think in budgetary terms, they might be the biggest in the UK.
Okay. So can you give us some context around the impact of COVID-19, the impact it's had in Scotland, first of all, and then also the experiences of NHS Lothian itself, how you've prepared and how you've coped?
Yeah, I think it'll be very similar to other health systems. Obviously, as we move through the various different phases of it, I'll still recall having the conversation with my family, and it must have been round about December time when they were talking about COVID and the impact of COVID, and we're talking about, well, it's in China and there's some issues round about there, but there's only been, and I kept on making the point to him, there's only been 2,000 deaths. Don't worry about it, there's only been 2,000 deaths. And if you roll forward to where we are just now and the significant impact it's had, I don't think any of us could quite have planned for both the impact that it's had on a Lothian population or a Scottish population or globally. And I think that's what's caught us all by surprise. So your comment about planning for it, I think we planned as we went along in terms of the system. The impact of lockdown, just in terms of how that worked its way through. So it felt as if within Scotland we had a longer time probably to prepare for what was the peak. I mean, we were watching on just in terms of how it passed its way through London and the impact it had in London. And so in terms of our position in Scotland, we probably had a bit more time just to kind of think about it and plan our services accordingly. I think the most obvious feature for within Scotland was just about how we started to plan for ITU. I think the service was genuinely concerned, having looked at what had happened in Italy, in the north of Italy, where where health services were supposed to be relatively good, where ITU beds were supposed to be pretty good. And I think there was a real shock to the system in terms of what we had to prepare for. I think in reality that has the degree of pressure that we've had on ITU hasn't been borne through. The extension in terms of the Louisa Jordan facility that we built through at the SECC and the expansion of ITU, thankfully, hasn't been borne through just in terms of that pressure.
So, sorry, what's the Louisa Jordan facility?
So Louisa Jordan was the expansion where we used an SECC facility. So you obviously had the other temporary facilities down south.
Similar to the Nightingale hospitals.
Yeah, so in Scotland we had a different name for ours, which recognised the kind of history within Scotland. So again, that's one of those facilities that we as a health system in Scotland have ploughed quite a lot of money into, but at the time we felt that was the right thing to do. And again, it's now one of those things that we're looking at and saying, right, so how could we utilise that facility in terms of repurposing going forward? So I suppose your original question about what did we do within Lothian, what would we do within Scotland, I think we did very similar things to what's happened in the rest of the UK. We tried to respond to it as best we could. We shut down a lot of our elective programme, which was a critical feature. We focused a lot of our clinical teams in terms of the front door and supporting ITU. We closed off a lot of our outpatient facilities and we moved more to a near you facility, a near me, which again was about maximising utilisation in terms of technology. We also emptied our hospitals. And again, there's a lot of criticism now just in terms of was that the right thing to do, just in terms of trying to take out a lot of delayed discharge beds, purchasing a lot of care in the community capacity, because we felt as if there was going to be a run on the hospitals. We felt as if there was going to be a real demand. And we did that at the time in the basis of our best information. And again, that's now one of those things that we're looking back at and saying, was that the right decision? Did we test our patients as quickly as we could have done in the way out? But again, testing capacity 3 months ago to testing capacity just now is very different. The view in terms of whether we would push people out without having been tested is very different. And I think people have to look at this through the reality of what we've learned over each of the individual months. I mean, this is a virus that's only been with us for about 150 days, so it is still young and we are still learning as we go forward.
Yeah. So you mentioned there that you had built the capacity. You were potentially expecting more than you experienced, more patients and more need to treat people with COVID-19. And as we record this, I hear that Scotland are just beginning to move into the phase 2 of their lockdown easing measures. So you said there the electives, the outpatients, you've stopped running those, empty beds, similar to most other people. What state are you in now? Are you bringing some of that elective work back in? Are outpatient bookings increasing? What's the current status and what are you looking at going forward?
So we've all been asked to do remobilisation plans, so to look at what are the things that we would want to switch on first of all, what are the bits of our services we'd want to warm back up again. Clearly issues like cancer has been something we've tried to continue to manage throughout the pandemic, and we've tried to do that in a safe way. So what we've been doing with all the services is just working through what are the priorities in terms of us switching back on. And again, switching it back on within an environment is still going to be a COVID setting for us. So we still have to recognise we're going to have red bits of the hospital, we're going to have green bits of the hospital. What does that look like? What does that also mean in terms of switching services back on? So it's not a case of we switched everything off and we switch everything back on. It's all the same. Again, you've got to remember we're going to be in a PPE-driven environment. So gowning up, going into the environment, taking that off, having breaks. The ability to utilise theatres and the throughput within those theatres is going to be greatly reduced. So that's not something we've been used to. Obviously, we've been looking over a number of years in terms of maximising our throughput. Now it's all going to have to be reduced down. So we are working with all our services just in terms of what is it we could do. So what are the services that we can switch back on? What are the real priorities within our services that we can switch back on? I think the added challenge, though, is it's really important to try and retain the gains that we've had during the past 3 months. I remember early conversations with Scottish Government, and the Scottish Government was saying, right, okay, what decisions have been taken? And it was that had financial consequences. It was really difficult to play that back to them because really we were in the early stages of the pandemic. We were making 10 to 20 decisions on a daily basis that would have taken us months to do.
Yeah.
Would have required short life working groups, would have required to take on consultancy organisations, would have been required to consult with the wider service. We were making really quick, agile decisions. And again, what we're trying to do is think, right, well, we did those things really quickly. Can we still do things really quickly? The things that we've put in place, are those the things that we want to continue on with? Because what we don't want to do is just move back into a service that maybe wasn't delivering the best services that we could do. So even things like our kind of care in the community, how has that worked? Is that a model going forward? So we have done a lot more care at home type models. And again, is that something that we want to continue on with? And I think we've also got to recognise that the public want to use their services slightly differently.
Yeah, the expectation's different, isn't it?
Yeah, I think people are still concerned. So people still coming to the front door, do I need to go and be a burden on the health service? And again, if you look at a number of the avoidable deaths, the number of changes in their deaths profile, some of those will have been driven because people wouldn't have been accessing primary care or coming through our acute facility. So now people are still very thoughtful about coming into the care sector and how they utilise it. But it's still really important to get that message across that we are open, and if there is people that have got risks, they need to be flagging up those risks or any issues they've got within both primary care and within the acute sector. But also at the same time, I think we just need to think people want to use their health service in a slightly different way. So the ability for people to have a telephone conversation with their GP. Now, something as simple as having a telephone conversation, it doesn't always have to be a sexy video call that takes place. And I think our GPs have become more adept at that as well, because I remember at the start they were saying, oh, well, we don't want to be doing telephone calls. And now it's become a way that we do business, which is great. The bit about using the video calls in the Near Me Now facility where you don't have to, I don't know, we always used to talk about the patients at the heart of our health service. Well, do you know what? A patient coming an hour's journey to come into a hospital for an outpatient clinic where they see the consultant for 10 minutes and then they've got to travel an hour's back. I mean, that's 2.5 hours out of the day. Well, do you know what? You could probably do that either over the phone or you could do that over a video call. I think there's definitely, our eyes have been opened in terms of how we can provide services. I think the easy way for a service to go back is just to revert back. Well, do you know that's what we did? We've got to book everybody into those clinics. And I think trying to stop allowing that to happen again, I think it's going to be something we're going to have to be much more measured about.
Yeah, definitely. I agree there. You mentioned about the speed and the flexibility with which you adapted to change and you made those decisions as an organisation. And that's something we're hearing about a lot, that in the remobilisation or the transitioning into the new normal, we need to take advantage of that ability. But I'll sort of counterbalance that with the discussion about, you said with hindsight, was discharging all those patients into the community, was it the right decision? Could you have done it slightly differently? So we need to make sure that we do make quick decisions, but they're the right decisions, or we don't delay the decision-making process. Do you think that's something within the governance arrangements? Would that be more locally, or would that be nationally that would look to change those?
I mean, Nicola Sturgeon has been very vocal and she's been very prominent. So, I mean, she does the daily briefing to everybody. And I always remember Nicola saying at the start, we will make mistakes. She will make mistakes, the health service will make mistakes, the public will make mistakes. But what we want to do is make sure that we learn from it as quickly as possible as we go through the process. I think there'll be a lot of reviews that will go back and there's bound to be a public inquiry just in terms of how we've dealt with it. But again, it's very difficult not to say that the decisions we've made haven't been for the right reasons. They've been for the right reasons based on the imperfect information at that point in time. And again, I always remember speaking to one of our clinicians, and it must have been around about January, February time, and it was about a quality directive that was taking place. And her concern was, at that stage, I was just saying we're going to have to start planning for this situation, but her concern was we are going to lose a number of clinical colleagues through this process. And that was her number one concern at the time. And I think we've all made decisions on the basis of what we think has been best for the service, has been best for the public. And whether they've been the right decisions or not, I think only time will tell. But it has been one of those things where I think in terms of governance, Governance, we've had to try and be as agile as possible. I know in discussions with the SG have been saying, well, it's been really good that we've made really kind of quick decisions. I mean, governance is there in some ways to kind of protect us all in terms of sometimes where things go wrong. And to be fair, we've had to be really quick in terms of some of those decisions that we've had to take. And it's maybe not been through the purity in terms of a normal governance process. It would take a number of months in terms of taking those decisions. So I think we've got to reset probably that the measurement just in terms of governance, and maybe just resetting, is it still appropriate to go back into all of those processes for taking decisions, which are sometimes probably the most obvious. And again, we all work in the health service because we can feel as if we can make a difference. We all work in the health service because we want to improve the health of our population. We don't all join the health service so that we can get involved in a lot of the kind of close discussions around about the politics of it. It's not what we do. But again, the reality is that sometimes does play into the decisions that we have to take, and it has to be something that we've got to consider.
Yeah. Okay, moving on to another topic slightly. What have the funding arrangements been up in Scotland to meet the demands of COVID-19?
That was a really interesting one, and it was something that came up early doors, and we were having a lot of conversations with Scottish Government colleagues because it was one of those ones where we were making decisions, we were making clinical decisions, we were making service decisions, we were making community decisions, but we weren't necessarily sitting at each stage and saying, right, okay, well, what's that going to cost? And have we worked that through? And has there been a cost comparative that that's the right decision? So it was very clear we were operating in a fluid environment, and accountants don't like a fluid environment. We like to have controls, we like to have checks, we like to have balances. It's something we struggle with. So it was, to be fair, something we designed in collaboration with the Scottish Government as flexibly as we could. We didn't want to stifle some of the decisions that had to be taken, but we had to recognise that there's still a responsibility. We're still those individuals that are charged with financial governance, so it's still really important that underpinned a lot of the decisions that were being taken. I think initially, the first few weeks of it, there were a lot of random decisions that were being taken. I think as we've moved through it, with the financial voice has been round the table. It's maybe not as been as vociferous as it usually is, because in a pandemic we have to take quick decisions. So where we are just now is we tried to take a mature discussion with the Scottish Government, and we are the finance professionals within our organisation, so it's our responsibility to follow that public pound and make sure it's spent appropriately as possible. So what we decided with the SG was that we would have delegated authority up to a specific level depending upon the size of your organisation. So if you think about my organisation, roughly about a £1.7 billion organisation, I've got a local mobilisation plan. So our local mobilisation plans is supposed to capture all of the COVID-related additional costs, whether that's health or social care. So at the moment, our plan says that our local mobilisation plan is about £150 million over the year. Now, that's a significant chunk of money. And what we agreed with the Scottish Government was that if there was any immediate decisions that within my organisation above delegated authority of £1 million, we would have to escalate that through to the Scottish Government. Everything below that, we would try and manage it as much as possible. That's fundamentally our job in terms of managing that anyway. And there was a bit about element of trust within kind of certain parameters, and those parameters have probably firmed up over the past couple of months. So that's where we started from. The reality was we made a lot of those quick, expensive decisions before we had got to a place where we had a financial framework. And so we've had to do a lot of kind of retrospection in terms of saying, well, what does that mean in terms of the money? What does that mean in terms of those decisions that we took? Because a lot of the expensive decisions we took was in terms of buying capacity within the social care environment. So buying beds for delayed discharges, buying up all the capacity that we could, which you were to an extent in a seller's market, because a lot of these places were restricted. Actually, when speaking with our integrated joint board colleagues, we actually get some not bad deals. People were trying to work with us as much as possible. People were recognising that we were all in this together, whether it was the private sector, whether it was the public sector, whether it was local authorities, whether it was the NHS. So people were trying to make the right decisions. So where we are now is that we are, again, continuing to work with the SG just in terms of how funding flows. There's been more of a focus in terms of cash flow for social care. So the bit about we've bought all of these care beds. So what happens is the money comes from us in health, goes through the IGB, will go through the local authority, and then it'll be paid to the private sector in terms of the capacity.
So the IJB, that's the Integrated Joint Board, is that right?
Yeah, so that's where primary care and social care comes together within the Integrated Joint Board. So having the two of those together seems to be the key area where we have got financial pressure, because it's about the cash flow through to our local authorities and through to the care homes themselves. So we've had to try and do some sustainability payments through to the IJBs and therefore onto the local authorities, which will therefore make payments into social care. Within the health sector, certainly within Scotland, cash doesn't tend to be a problem for us. So we operate in collaboration with the Scottish Government. So we cash flows pretty easily for us. So what we've agreed with them is the key break point will be round about our Q1. So we tend to be operating quarterly cycles in terms of our forecast for the year.
Yeah.
So what we have said is after Q1, we'll take a status in terms of what all the costs are that are coming through the system. And at that stage, we'll have a mature conversation with the SG just in terms of how does those actual costs bear against what was within our mobilisation plans. And then we'll make allocations in the back of that, in the back of those 3-month results.
So that budget associated with the mobilisation plan, was that over and above the 1.7 billion?
Yeah. So the 150 million was what we felt was going to be the impact of all of the decisions that we were having to take.
Yeah.
Now, when you roll all of those costs together for all of those health boards across Scotland, that's significantly in excess of what have been identified from Treasury at this point in time. And I know there's ongoing conversations with Treasury just in terms of how everything's going to be funded. And on a daily basis, there's ongoing conversations about whether it be hospices or PPE or the flu vaccine. So there's different allocations coming at different stages. I mean, where we stand just now, I think the additional resources that we've got being allocated from Treasury is about 780 million across Scotland, but again, there's a lot of asks against that resource.
Thanks. So Craig, as we speak, we're both sat in our individual homes, probably about the furthest apart in the UK that you can get. What's the impact been on the finance team at NHS Lothian? Are they in the office? Are they at home? How are they coping with things?
I mean, our team, our finance team within Lothian is about 250 people. So early doors, we tried to be sensible. So what we just said is if you've got mobile technology, go home and work from home. If you haven't got mobile technology, we'll space everybody out within our location. We've got a city centre location, which is just outside, just on Princess Street, and it's lovely. It's a lovely modern office block. So we had the ability within that open plan to move everybody about. Over the period of the next few weeks, we had daily resilience meetings with our team just about, right, okay, how do we get the tech in place and how do we get people working from home? So that pretty much took probably about a month before we had enough laptops for all and sundry, before we had a tech sufficient for people to work from home. So pretty much everybody is now working from home. And it's been really interesting because, I mean, days gone by, we had lots of conversations as team before COVID about the ability to work from home. I mean, all the evidence or most of the evidence says that people work from home, you have less sick days, you're more motivated and you're more productive. I mean, that's always been the case, but getting people into the mindset that you can work from home has been quite difficult. And if you think about it within the health service, we struggle a bit with trust. We work on the basis of if you're in the office and you're working your hours, you're pretty productive, rather than a case of, well, do you know what? It's really about how you can be flexible and productive at the same time. So I think that trust boundary has been pushed to an extent. We now trust people in terms of working from home. So that whole auspice about, well, only a third of people could work from home. I mean, now we've got all of our teams working from home. We've got payroll, we've got procurement, we've got management accounts, we've got our capital teams, we've got financial services. Everybody's working from home. We've probably got a few stalwarts who are still coming into the office, who are close by. So we've maybe got a handful of people and it suits them to work from the office. The office is safe, the technology is there. If they feel that they're happy to come into the office, we've been content to support them. So yeah, pretty much everybody's working from home. I think it's one of those things now, and we've been trying to be helpful. So our immediate position was about, you need to have the tech, you've got to have a computer, you've got to have a laptop, you've got to be able to mirror in home tech. And now, a few months in, what we're kind of saying is, right, okay, well, how's everybody's back? Have you got a desk? Do you need a keyboard?
Yeah.
Do you need a mouse? Do you need a headset? So we're just doing a piece of work with everybody just now, because it does feel as if for the foreseeable future, even for the next few months, people are going to be working from home. So we need to make sure that they're comfortable and we're not impacting in any of their kind of health needs. It's been interesting over the past few weeks. We've been kind of soul searching as a senior team just about how are the team? How are they at home? And you've got a kind of 80-20 mix. Some of them just love it and they're kind of great about it. But I think the longer it's gone, a lot of people are missing the social engagement. So one of the comments that was made was, well, do you know what? We get all the kind of bad stuff about the work. I mean, we get all the work that still comes through. We don't get any of the good stuff in terms of that human contact, a bit of banter about the office, a bit of social engagement. So one of the admin team, she was kind of saying, look, what are we going to do, Craig? And I said, well, why don't we think about different options? So she's come up with an idea about a coffee morning. So we're now going to do it within individual teams and have a coffee morning just within those individual teams where you can get everybody up on your Windows 365 and through Teams. And we're also talking about having a library sessions as well, where you just open it up and you've got lots of people that sit in the background and you just sit and do your work. So I think that whole social interaction is really important. And
it's developing and evolving.
Yeah, and I mean, it's different because these are all things that we aren't used to doing. And I suppose one of the underlying platforms that I didn't mention was we were going into Teams literally weeks before this all kicked off. So, right. I mean, it was a godsend for us. I mean, it was one of those things that would have taken 6 months and we wouldn't have fully utilised. And now it's one of those things that everybody's embedded it. I mean, it's just the way that we do business. So, I mean, that was a real bonus for us. And it was one of those things that we were fighting against because we weren't sure of the benefits of it, because colleagues from national boards who were trying to roll it out were saying, well, you'll not have to have meetings. You'll not have to go to meetings. We're saying, well, what a lot of nonsense. We've done that before. We've had Skype and everything else, and everybody does it, but everybody continues to do what they normally do. And the reality is Teams has become a way of life. I mean, we go from one Teams call to another Teams call to another Teams call. So, yeah, it's been really interesting just in terms of how we've made it work and how some people have been real advocates for it and have pushed it forward. But I think there has been those kind of different elements of change. So if you think about the change curve and you go through the various different stages of, well, you fight against it, you're not too sure about it, then you accept it, and then coming out the other side of it. But I do think there is a wider bit about we just need to support our teams to make sure that they're fully set up at home, they're safe at home, they are comfortable at home, but also we build that aspect in terms of the social infrastructure that you can't normally get within an office environment.
And we've been hearing about finance colleagues getting involved in different areas of the trust and different roles that they wouldn't have before. Have you guys been getting involved in things outside of finance?
It's an interesting one, isn't it? Because I've been in the health service for goodness a few years. And I must admit, over the past few months, I've learned more about the service than I have for a number of years, because you're thrust into the middle of it. And what you tend to find, and certainly what we found with our teams, is that we've all just wanted to help out. So there's a bit about, initially we're all standing on the sideline saying, right, okay, just go on about your businesses. Right, we'll just step back. Financial governance, we'll just step back. There's no point in us talking to you about your statements or your budgets or your efficiencies. So we all step back. But very quickly, there was a realization about our guys are good at things. We are good at counting things. We are good at bringing structure. Yeah. We are good at utilizing technology. We are good at looking at data. And so a lot of our guys have gone off and supported in a number of different pieces of work, whether it be about setting up databases for the number of different masks and PPE that's come through, whether it has been modelling through the activity flow that was coming along, whether it's been looking at the modelling in terms of the sickness that we've had, the link in terms of supplementary staffing, the link in terms of our clinical teams, the link in terms of our public health data, the link in terms of what our primary care. So we've done a lot of work in that area in terms of how we've used our data modelling skills. We have had a lot of our team who have been very helpful in terms of managing PPE usage within the hospital settings. I mean, it was becoming a bun fight in terms of who was getting what items of PPE. There were shortages on a daily basis. Again, we've been using our guys in terms of doing additional top-up within the ward environment. We've been trying to support our procurement team as well, just in terms of any specific aspects that they've got, because the amount of work that these guys have been going through, the number of calls and meetings we've had over the weekends just in terms of trying to support them. I mean, people have been working really, really hard. I think though, taking it back to a strategic level, so when we kicked it off, we did a bit of conversation internally, and what we talked about it was all about mutual aid. So how could we mutually support ourselves within NHS Lothian in terms of the finance team? So the focus was very quickly in terms of our procurement team and our payroll team. They were the two most important services because people needed to get paid and procurement still needed to be able to buy things. So that was what we did initially. We then looked at it in terms of mutual aid within our wider organisation, and that's where we had people going out and doing various different roles across our organisation. And at the same time, at a strategic level, we've been trying to provide mutual aid to other boards. So other boards, because we are a larger board, we probably get greater resilience. So we've been trying to do mutual aid with other boards, and on a weekly basis, we were having weekly calls just about, right, what things can we support on? What are the things that we need to be looking at? Right, has anybody got a solution for that particular problem? Is there anything in terms of the technology? Is there anything in terms of payroll? If payroll teams are going to go down, what are we going to do about it in terms of procurement?
And is that something that you were good at previously, working with the other boards and working closely, or do you think that this experience will help bring that together more often in the future?
I mean, we've got roughly just under a population of about 6 million. We have got a lot of boards. So we've got the kind of 50 mainland boards and we've got the special boards as well. I mean, we tend to work pretty well together. We've always, as partner agencies, we've always had a very close finance network within Scotland. That's always been the case. But it has certainly thrust us together that bit more, and it's certainly helped us to work that bit closer in terms of some of the projects that we're trying to kind of kick off. But I'm trying to think if there's anything specifically that we've changed that wasn't there. I mean, we've been having regional projects just about trying to deliver regional payroll functions or regional procurement functions. Again, that's probably just increased the pace of that a bit more.
Just enhanced rather than changed, then?
Yeah, I think it has enhanced it. We all try and support each other as much as possible. We all try and assist each other as much as possible. I think there's also been a test as well about during the pandemic, having that individual function that you're able to manage has been something that people have welcomed. Whereas I think the concern about having a regional centre might be something that we're going to have to just kind of test just in terms of what those models look like. Because the model that we're trying to put in place might be different through the lens of COVID. And I think we've got to kind of just think about that and retest some of the learning that's come with that.
So Craig, final question from me. As we look to remobilising and transitioning to providing regular services once again, what are the main lessons you've learned over the last few months?
I suppose it would be one in terms of the pace of change. I mean, the health service does take a while in terms of making changes. And the reality has been that we've made a lot of changes much quicker than we have done before. So I think that's a lesson for us all. We have made that work. I think there's definitely a wider appreciation about the skill set of others and the NHS family, and just trying to understand all the different things that people do. I think there's also a wider recognition about back office functions. Back office functions have pretty much stood up. We've taken on a lot of tasks that a lot of front office functions or front-facing services have kind of really recognised that we have got a skill set in terms of supporting. So I think that's probably brought us a bit closer together. What would I think is that we will do differently going forward? I'm a great believer in you ask the silly questions until you understand the issue. I'm a great believer as well in terms of that for you to be a fully functioning senior finance individual that adds value, you've really got to understand the service. And I think that's something that we've all had to get to grips with. a bit more, really, in terms of understanding the decisions that have been taken, understanding the way that the system has been set up, understanding the number of beds that we've got actively in any one day, understanding the number of ITU beds that we've got any time, the bit about understanding what we've got within the social care and that flow through in terms of how that works, understanding the demands that are being placed on clinical teams and how they've now had to operate in a slightly different way. I think that's something I personally will take away from this, that I've now got a better understanding. I always felt as if I had a pretty good understanding, but I've got a better understanding of how it all hangs together. The other bit that I've also noticed as well is that a number of my senior team and a number of our young accountants are now going, well, do you know what? I have been working in that service and working quite closely with it, so I might have a role in general management going forward. And I think just helping people to get to the right roles within the services is important for us all. We're really keen to bring in good people into the health service. We're really keen to have good, dynamic individuals within our finance team. But sometimes that might be a stepping stone to general management. And I think helping people to get to those right roles is something that over the next months and years, I think there'll be a greater movement between people rather than just saying, well, I'm an accountant and I just deal with accountancy, to, do you know what, I think I might want to have a greater depth of career, maybe at an operational level, which will be interesting to see. I'll be sad to see some of these good people go, but I can understand why they will move on in a slightly different shaped careers.
Thanks, Craig. Was there anything else that you wanted to share with our listeners?
We had a conversation with directors of finance yesterday, and one of the things we were talking about is we do our conference every year, which is always a good opportunity for us to get together. And I suppose just if MD's listening in, the plan this year is that we're going to have a virtual conference. What that will look like, how that will take shape, we're not that sure at the moment, but I suppose it's just something for people to watch out for. We will hopefully be using some of HFMA's technology so that we can have a large number of individuals involved, and it'll be a free fee type option, and we will have some good speakers, I'm sure, and we'll try and do some innovative work. So I suppose it's just something for people to watch out for coming forward. I would also put out the plea about, if you look on the HFMA website, there is so much information in terms of the directory about how different areas are reacting to the COVID type environment. There's lots of really useful information on there. And again, it's always one of those things that if you've got a problem, there's somebody else that will have had that same problem, and there will be some information on there that will assist you with some of the answers that may be available.
Brilliant. Thank you, Craig. Thanks for sharing your thoughts with us this morning, and best of luck for the continued fight against COVID-19 and your transition, I guess, into whatever the new normal may be.
Brilliant. Thanks very much.
All of the HFMA's COVID-19 related briefings, blogs and news articles are openly available on our website hfma.org.uk. There is no need to be a member to access these, so please tell your colleagues. We have also launched a forum where finance colleagues from across the NHS can discuss issues and challenges in a safe space. You can sign up via the link in our network section of our website. If there are particular topics you would like future podcasts to cover, then please get in touch via our email address policy@hfma.org.uk. Thank you for listening to HFMA Talk, and don't forget to subscribe to this podcast to keep up to date with new episodes.